for coming tonight as part of our Global Health Lecture Series. I will be presenting two speakers that we have tonight to talk about something that I know you can't avoid hearing about in the news, and one of the newest world epidemics, Zika. And in fact, today I even had to call Dr. Epps and the Department of Public Health for a newborn baby that I was rounding on today, 2 days old, whose mom has significant travel history. So it is here among us, and we all need to know about this very important topic. So I'm grateful to Dr. Epps and Dr. Deskalaki for coming tonight. Dr. Irini Deskalaki is a medical epidemiologist with the Office of Infectious Disease and Epidemiology of the Delaware Division of Public Health. She actually comes to us from Athens, where she was born, and received her medical degree from the School of the National University of Athens after completing her mandatory service as a public health official in a rural, underserved area. She participated in various research projects, including in infectious disease in Greece. She then trained in general pediatrics in the University of Athens and Monmouth Medical Center in New Jersey. She completed her fellowship in pediatric ID at St. Christopher's in Philadelphia, where she then was a faculty member and practiced peds ID there. She also served as a medical epidemiologist for the Department of Public Health in pediatric tuberculosis. And then she has now come to us in Delaware and joined the Delaware Division of Public Health to work on emerging and hospital-acquired infections. And she will be co-presenting with Dr. Stephen Epps, who wanted to keep this short and sweet, so he is Peds ID, the Vice Chair of Pediatrics at Christiana, an Associate Infection Prevention Officer at Christiana. So thank you to you both for being here tonight.
So the way we've divided this up is I'm going to cover some basic epidemiology and background information and the clinical manifestations, and a little bit on testing and treatment. And then Irini is going to cover the important part, which is public health response and prevention. So John Donnelly asked us, now 3 months ago, he said, let's do this in September because it'll be right after the Olympics and all these people will be returning from Brazil with Zika. Well, you're right about the timing, but it hasn't come to pass that a lot of people have brought back Zika from the Olympics that we know of, but this is a rapidly moving field. It changes every day, so we'll keep our eye on that. So these are flaviviruses. Flavy is yellow. There's a bunch that you've heard of for years and years: yellow fever, dengue, Japanese encephalitis, West Nile. But the one that has just made it to our collective consciousness most recently, just in the 8 or 9 months of this year, is Zika virus. I don't claim to be a public health expert, she is, or to have done any original research on Zika, but like many of you in the room, I have been an avid Zika watcher for the last 8 or 9 months, and it's fascinating and extremely important public health problem. It's not new. Zika was first isolated from monkeys and mosquitoes in the Zika forest of Uganda back in 1947. Not much was made of it. It didn't seem to cause a lot of human disease and certainly was not epidemic. But we had some isolates from Uganda, Tanzania, Nigeria, various places in Asia and Africa. Probably became a little bit more well-known in 2007 when it hit the island of Yap and then subsequently spread to French Polynesia, where there was a significant outbreak amounting to at least 10,000 known cases. And at that point, it became associated with certain other bad things, such as Guillain-Barré and possibly autoimmune neurologic disease besides Guillain-Barré. It wasn't until retrospectively looked at that we knew that it also caused microcephaly in that outbreak. It then spread farther through Southeast Asia and the Western Pacific, and then proceeded into the Western Hemisphere in early 2014. It may have hit Haiti first, there's some evidence of that, but it really became known in Brazil, where it's caused widespread disease in most of Brazil. Then spread to other parts of South America, Central America, and the Caribbean. In December of 2015, again, this is about when it really started making the news, the Brazil Department of Health estimated that somewhere around 1 million people had contracted Zika virus, and they began to experience an increase in the number of cases of microcephaly, as I'll show you. So it kind of proceeded in this way, from west to east. You can see the mouse. So that by the time we got here to the last 8 or 9 months, it had spread really throughout the Americas, with very few places left untouched. February 1st, the World Health Organization called this a public health emergency of international concern, and they called for a coordinated effort to improve surveillance, intensification of mosquito control efforts, and expedition of vaccine and diagnostic test development. So this is the map of the Western Hemisphere, where there's currently active Zika virus transmission. So the United States was added to the map this summer, as you all know. I'll touch on that in a few minutes. But pretty much all countries, with the exception of Chile and Canada, and this includes the Caribbean basin as well. So in total, 70 countries and territories have reported Zika virus since 2007. 11 countries have had person-to-person transmission, which I'll explain. There are 2 lineages of the Zika virus. There is the African and Asian lineage. It appears that the Asian lineage is what is wreaking havoc throughout most of the world, and seems to be much more associated with development of neurologic complications, both in older children and adults, but more specifically and more importantly in the fetus. These are the regions of the United States that have experienced the most Zika. As I'll show you in a moment, most of this is travel associated. But there you see areas which are densely populated and which may have a preponderance of returning travelers. This is very small font, but hopefully you can make it out. So in the continental United States, there have now been 2,964 cases of travel-associated Zika virus disease. This is as of last week. So roughly speaking, 3,000 altogether. 624 are pregnant women. We now have had 56 cases of mosquito-borne, locally transmitted Zika virus infection, 23 cases that are known to be sexually transmitted, 7 cases of Guillain-Barré syndrome, and we now have some pregnancy outcomes that we can talk about. There have been 22 congenital Zika virus cases with significant birth defects so far in the United States. In the U.S. territories, which include a lot of the island countries, and quite honestly, Puerto Rico in particular has been extremely hard hit. There have been over 15,000 cases, almost all locally acquired, much fewer that are travel associated. 971 in pregnant women, 32 cases of Guillain-Barré syndrome, and so far, really very few live-born infants with birth defects. So you might say, now why would that be? Because the territories, like Puerto Rico, had so many more cases. Well, they've had most of theirs transmitted in the last few months, whereas a lot of our travel-associated cases were much earlier in the year. Those women, many of those women in the United States have delivered. A lot of the Puerto Rican women have not yet delivered. This was a map that was developed a couple of months ago, estimating which areas of the United States would be most hard hit by Zika, and I'm talking about locally transmitted Zika as well as travel associated. And this is based on the climate of these regions, travel patterns, and the presence of the necessary mosquito vectors. And so you can see that Florida, hard hit, and that has come to pass. And areas of the Northeast, mostly because of returning travelers, and a lot of areas in the southern United States and the West Coast. This is made up. This is based on good data, but this does not represent actual Zika virus cases. So So you had to have been living under a rock if you have not heard about the Florida cases in the last month or few weeks. And there are really only two areas of Florida that have been hit, and they're both in the Miami region. So this is Wynwood, which is right there, which is an artsy-fartsy area of Miami, and then there is the area in Miami Beach that's shown right below that. And so we know that there have been mosquitoes identified that have carried the Zika virus in those areas, and there have been a number of cases, several dozen human cases, known to be infected in those two very restricted geographic areas. This chart shows what happened in Puerto Rico, and this was published in April. And so over to the left, you see three viruses, Zika, dengue, and chikungunya virus, which are all at relatively low levels. This is the winter here. And then as we got to late winter and early spring, we had a little bit of a bump in chikungunya and dengue cases, but look what happened to Zika, which really took off in Puerto Rico. And some of our best epidemiologic data now come from Puerto Rico, where they have been very careful to document clinical manifestations and other important aspects of their epidemic. So I heard an interview with Anthony Fauci on NPR earlier this week. Anthony Fauci is the director of the National Institutes of Allergy and Infectious Diseases here in the United States. He's been in that position for 30 years, great guy. He said he's worried about Florida, but what he's really worried about is Singapore. So it hit Singapore in late August at the site of some building construction, and it was probably imported by some workers. And then just in a period of a couple of weeks, they were able to count 330 locally acquired cases, including 8 pregnant women. So it really has just taken off. Why is Dr. Fauci worried about this? Because Singapore is a huge metropolis with 5 million people. It's a huge hub for tourism and trade, so lots of people coming and going with the ability to then take the virus on a boat or a plane and disseminate it to other areas of Southeast Asia, Indonesia, and so forth. It's got the perfect climate, kind of like Florida, and it has the necessary vector mosquitoes. So I think we really ought to keep our eye, if we believe Dr. Fauci, on what's going on in Singapore. So with respect to that, I found this information online. I point out it has not yet been published. I'm not sure it's peer-reviewed, but I thought it was fascinating, and based on their methodology, I think it may be reasonably valid. So Dr. Khan is a infectious disease doctor, no relation, right?
No relation.
In Toronto, and he did some mathematical modeling and based his calculations on these things: the number of passengers traveling by airplane, number of days per year when various countries' climates allow Zika spreading by mosquito, the ability of these various nations' public health systems to respond to a Zika virus epidemic, the number of people living in zones suitable to Zika transmission, and based some of it on what has happened in the past in these countries when there have been outbreaks of dengue, which is spread in a similar fashion. So using these basic aspects or assumptions, he created some modeling to estimate that these would be the number of people at greatest risk of Zika virus if these countries began to have endemic transmission. So hardest hit will be India, followed by China and all the rest of the countries that you see, mostly in South Asia, Southeast Asia, and Africa. So while we're worried about Miami and Miami Beach, and we're correct in being worried, I think we really have to look more globally at what could happen given various assumptions when this virus makes it to other locations. Again, sort of underscoring the importance of Singapore. All right, Zika is transmitted in 4 ways. Mostly it is by mosquito bites, which Irini is going to talk to you more about. Mother-to-child transmission, which results in the severe birth defects that you all know about. Blood transfusion, which has mostly been identified as a mechanism in Brazil. And sexual transmission, which has been fairly well characterized here in the United States. So these are the two mosquitoes. Aedes aegypti is by far the most important vector, but it's also found in Aedes albopictus. You also see there on that slide the other diseases that these mosquitoes can transmit. So both can transmit Zika, with aegypti being the more important vector. We learned probably in February and March that sexual transmission occurred. So this would be somebody who had travel-associated Zika, came back, symptomatic, at least the first cases were symptomatic, and then transmitted it to a partner who had not had travel or any other way to possibly get Zika. And so it was established by those case reports that this could be sexually transmitted. So at first it was just symptomatic men transmitting it to women. We now know that it can be asymptomatic men. It can be men transmitting it to men transmitting it to women, women transmitting it to men, and sex toys playing a role as fomites that can enter the equation. We also know, like Ebola virus, that the virus can survive in semen for a long period of time. It only lasts in the bloodstream a week or two, a little bit longer in the urine perhaps, but in other secretions, especially semen, it can be a lot longer. We learned early on, and this is obviously makes sense, that condoms can interrupt transmission by the sexual route. And just last week, the World Health Organization recommended that both males and females who travel to areas of active Zika virus transmission abstain or practice safer sex for 6 months after their return. I thought the timing of this, interestingly, was after the Olympics. That probably should have been established before the Olympics, although I think other public health authorities had said that. Irini is going to talk to you more about blood donation, but until very recently, blood was screened only by means of questionnaires. If you donated blood, you know that you had to answer those questions. When endemic Zika virus transmission was noted to occur in Miami, the FDA said, questionnaire is not good enough, we actually have to screen. So within the next few months, all blood banks are going to be screening all donated blood for Zika virus. So this is a question that we didn't have a good answer to early on. How likely is maternal fetal transmission? In the French Polynesian outbreak, it really wasn't recognized until retrospectively. So we began to see it in Brazil, and then people went sort of backwards and said, did we see that in French Polynesia? And they did, but they thought it was a low rate, and they estimated maybe around 1%. But early on in Brazil, it looked more like 29%, at least in one early study, would have some abnormalities identifiable in a pregnancy complicated by Zika virus infection. We've also learned that it's probably like CMV and toxoplasmosis in that earlier gestation infection poses the greatest threat and results in the most severe sequelae for fetuses and the infant, although Irini is going to explain to you that late gestation infection is important as well. So for the non-fetus, these are the main clinical manifestations. First of all, only 1 in 5 people is symptomatic, 80% are not. Those who exhibit symptoms generally have a mild illness lasting a week or less. Symptoms begin 2 to 11 days after the mosquito bite, usually with the onset of low-grade fevers, achiness, arthralgias of the small joints, conjunctivitis, headache, malaise, and a fairly nonspecific maculopapular rash, pictured here. So, I mean, you would look at this and you would say, that looks like a viral exanthem, but there's nothing really characteristic about it. Like Lyme disease is obviously, very characteristic. This could go along with a number of viral infections. So in the areas of the Western Hemisphere that are most affected, you can also find dengue virus and chikungunya virus. So this chart contrasts the clinical manifestations of those 3 infections. So all of them cause fever, all of them cause achiness. What sets Zika apart is the presence of conjunctivitis, which is not found in the other 2. Now, dengue, as you may know, can result in hemorrhagic fever and shock. That, thankfully, is not seen with Zika virus infection. Guillain-Barré was noted in the French Polynesian outbreak, 42 cases in all. And then we began to get an idea in January, February here in the Western Hemisphere that Guillain-Barré was associated with Zika virus as well, but it was largely anecdotal and it was based on not very good reporting. But just a week before last, an article came out, a letter to the editor of all things, which I think was an incredibly important observation, tucked in the correspondence, that really I think shows beyond any question that Zika virus infection is associated with Guillain-Barré. So here on the top panel, you see a number of the Western Hemisphere countries that are most hard hit by virus. You see in yellow the Zika virus cases, and in green the Guillain-Barré cases, and there's an absolute correlation with the peaks of Zika virus disease and the peaks of reported Guillain-Barré syndrome. So this is a CDC drawing of microcephaly, and throughout the media reporting in the last 9 months, they focused on microcephaly. I guess it's easy to say, but it is far more than just microcephaly. Linda, this is my son. I put him here because his head is at the 3rd percentile. So, by all rights, you could say he's microcephalic. But he's actually in law school and doing okay so far. My point is that Zika is not just microcephaly. It's extreme microcephaly. And it's because of abnormal brain growth, development, and brain damage. Again, in a lot of developing countries, they don't have the imaging modalities that will give you the pretty pictures that I'm about to show you. It's easy to measure the head circumference, and that's really what got us on the way to understanding that this virus did something to fetal brains. So when I first gave a lecture on this in February at our infectious disease conference, this was all we had to go on. Not very much real concrete data that Zika virus was associated with microcephaly or anything else. So just a handful of cases where we had PCR data, and so it wasn't really certain. But now we're very certain. So the Brazilian Zika embryopathy task force was looking at infants from late 2015 on to the present time. By the time they looked at 35 infants, it was very, very clear that the Zika embryopathy was a very characteristic clinical entity. These initial cases all were born to mothers from a Zika endemic area. Most of the mothers had reported a rash in the 1st or 2nd trimester. The infants were severely affected with head circumference greater than 3 standard deviations less than normal, and fairly typical imaging patterns, including calcifications, migrational defects, smooth brain called lissencephaly, enlarged ventricles, and something that I don't think people originally had figured out, which was arthrogryposis. As of last week, there are now 1,900 cases of confirmed congenital Zika virus infection. Probably a lot more than that just haven't been confirmed. Mostly this is in South America, 22 so far in the United States. And we know that most of these severe cases, like on the preceding slide, were from early gestation infection. So here again are some imaging findings. So these brains are very abnormal with significant neuronal damage, calcifications, brain tissue loss, and so forth. The first best characterized case was that of a woman who had been working in Brazil, returned to Europe, and she had known about Zika and had some ultrasounds in Brazil that were okay, returned to her home in Europe, and they followed her pregnancy through the 2nd trimester with ultrasound and began to worry because they found calcifications in the placenta, which is here, and brain abnormalities including extraaxial fluid, ventriculomegaly, and calcifications. So I kind of gulp when I say this. The woman elected to have a late 2nd trimester abortion, and the baby was autopsied, and there you can see the findings, the gross findings in the brain, which are these punctate areas of brain damage, enlarged ventricles, the smooth surface of the brain. This is the histopathology and immunohistochemical staining showing areas of abnormality throughout much of the brain. Here is electron microscopy showing the characteristic viral particles that you can see in the upper right panel. And they were actually able to quantify the number of viral particles in the brain of this poor baby, and they found that 10 to the 5th, at least 10 to the 5th virions per ml of brain tissue were present. So very overwhelming catastrophic infection in this particular infant. In March, we learned that ocular involvement was common. So this article that was published in JAMA Ophthalmology by some Brazilian ophthalmologists looked at 29 infants with 58 eyes, and they were able to identify that in 29% of the eyes there were abnormalities, including the focal pigmental changes that you see that looks very much to me like toxoplasmosis injury, chorioretinitis, optic nerve abnormalities, coloboma, and lens subluxation. Arthrogryposis, for those who are non-pediatricians, is a pattern of multiple joint contractures, club feet being one that's probably familiar to you all, but it can be upper extremity contractures as well. And arthrogryposis results from in utero lack of movement of the extremity. You know, babies are flailing around all the time in utero, but because of the damage to the motor neurons in these babies, they don't move and they get these joint contractures. And this seems to be a pretty common pattern in many of the babies with congenital Zika virus infection. This was just published last month from MMWR that demonstrated hearing loss in many of these kids. This is small font, I don't expect you to read it, but it's common, and it seems to be most prominent in babies who were infected early in gestation and in babies with severe central nervous system damage in addition to their hearing damage. I'm just going to show you these to say that they're there. You're going to hear a bit more about it from Irini, but this has been updated a couple of times. And if you want to know anything about Zika virus, almost anything, go on the CDC website, and they update it constantly with new findings and new recommendations. So I show you here the pregnancy guidelines from the CDC, showing you how you're supposed to manage the pregnant woman or the woman who might be trying to become pregnant. And here is the algorithm on managing the infant with possible congenital Zika virus infection that no doubt Carla was looking at earlier today when we talked. Just a bit about testing, because you're going to hear more about it from Irini. There are really two ways that you can test for this virus. One is by PCR, looking for the RNA, and the other is by antibodies. So that's kind of like what we do for almost all viruses nowadays. So the RNA is present in very early infection, may last in blood for a week, may last in urine for a couple of weeks, longer in pregnancy. And then sometime in the first couple of weeks, you'll begin to see the anti-Zika IgM antibodies that persist for weeks to months afterwards. So those are two main modalities to be able to diagnose and to some extent time a Zika virus infection in an individual patient. There is a commercial test which came out a couple of months ago that was authorized by the FDA under EAU. So along with the approval from the FDA came some very strict guidance from FDA and CDC about how to use the commercially available test, which really parallels what the CDC has been saying for a long time, which you're going to hear more about from the next speaker. So even though it is commercially available, it's discouraged that you test people outside of existing guidelines. It's also very expensive. So there's not much to report on antiviral therapy, unfortunately, but if you're paying attention, this just came out in the news about 2 weeks ago that researchers from several institutions collaborated and just screened a whole bunch of compounds that are already FDA approved for various things in the United States, 6,000 compounds to be exact. And lo and behold, they found some that actually seemed to have Zika virus activity, one of which I learned about in medical school, niclosamide, which is an anti-helminthic drug. So will these at some point play a role? Don't know, but it shows that there's promise, and I think we will at some point have anti-Zika viral therapy. The niclosamide kind of reminded me, if you remember in the early days of HIV, Suramin, which is an anti-parasitic drug, was used in HIV infection with some modest successes. So stay tuned there. There really needs to be a vaccine. So far, there is none available, but there are a couple under development. The one that is the farthest along in development is being investigated by a partnership between Inovio, which is a private pharmaceutical company not far from here in southeastern Pennsylvania, and the Wistar Institute. They have finished their animal trials. They seem to have a vaccine with robust ability to result in antiviral antibodies. The NIH is also looking at a candidate vaccine, but it's a long way away. Even the Inovia Wistar vaccine, which is the farthest along, probably is 18 months until any more widespread human trials or use in human populations. Wouldn't it be nice if prevention was this easy? So I'm going to turn this over. to Rini.
So I have been tasked to talk to you about how Zika is a public health problem and what do we do. And Zika is indeed the perfect public health problem. And because the constituents of the public health problem are the prevalence of the disease, and we have it through outbreak in the South and Central America, we have, of course, impact to the individual and in a very special population that can be very adversely affected. And then we have impact to society, but we have some potential for prevention. So I'm going to talk to you a little bit about the epidemiology of Zika virus in Delaware and about the Delaware action plan that we made at the Department of Health, which means, what implications and measures, we had to institute. And, the fun part of the job for an ID doctor is always fun to learn about vectors. So there are Zika cases in Delaware. And Dr. Epps did a great job, before my talk to help me out, because we knew Zika is going to come to Delaware because we know any infection anywhere in the world, it's only one plane ride away. That's what it takes. It doesn't have mosquitoes to fly here. We don't have to have that. Just, a plane ride away, like a human is going to bring it. So we have 13 cases, and 12 are laboratory confirmed, and there is one inconclusive, and it just so happened that this was a pregnant woman. So that's why we have a pregnant woman in our Zika registry, despite the fact we have no pregnant woman with confirmed lab infection. And we don't have any mosquito-borne infections in Delaware, and we haven't had any sexually transmitted diseases in Delaware. But we're in the lookout, and that's where we stand right now. So the Zika Action Team was formed, which is essentially an elaborate way to say that lots of people had to be involved in order to do surveillance, laboratory, be on top of that. And with a disease that has so many different ways of transmission, you need lots of people involved, like the vector control department and then blood safety. And of course, we have to put our brains down and kind of, sit down and think how we're gonna reach the special population, the pregnant women, and of course their providers. And then the Zika Action Plan happened, which some of the domains you see here, I'm gonna just elaborate about these domains that I thought they were the most important and the juicier ones, I guess. So first of all, we need targeted communication. We need to reach the public, so there is no panic, but there is awareness. We need to reach the healthcare providers. We need to reach special groups. We have created a special Zika page in the Delaware Department of Health website. If you just Google Zika in Delaware, you're just going to be right there. So what do we tell people? We tell them how to avoid mosquito bites, okay? I mean, there are some common sense stuff there, and fine mesh screens, and EPA approved disinfectants. I mean, there is some guidance and some education to be done there, because there is lots of alternative stuff out there and things. We want things that do work. and protective clothing, and so on and so forth. What is very important is this, and we're going to talk a little bit more about that because of the way these mosquitoes are and the vectors. And this is from the malaria campaign, actually many, many years ago. And I don't really know why they were asking, people to help with the elimination of the mosquitoes back then, but that's what we need right now. We need partnership with the public. And then it came up that Zika is now a sexually transmitted disease. So, as Dr. F said, the transmission can happen in all kinds of relationships. So we have specific guidance about that, although we don't know many things that we would like to know. So the guidance right now is that for a female return traveler, with or without symptoms, it's better if they avoid unprotected sex for 8 weeks. Now, it is changing for a male return traveler because of what Dr. Epps told you, that the virus stays in the semen for way longer than the viremia and the viruria. So you need, if the male return traveler is asymptomatic, okay, he can avoid unprotected sex for only 8 weeks. But if he has been symptomatic, then we're talking 6 months. And this is obviously from the timing of the onset of symptoms, or the last exposure if they have been asymptomatic, which means essentially the day they came back. Now, the other important guidance is on a traveler who has a pregnant partner. So essentially we're saying, just forget about it during the pregnancy, unprotected sex, that is. And then, of course, we have lots of guidance for pregnant women, specifically, we counsel them how they have to avoid really to travel in these areas. Mosquito avoidance is very important for them, and of course, we are testing them. And the focus of the Zika action plan is truly for pregnant women. We talked about that. The people who we don't want to be testing are the people who would like to not take the guidance but do something else, and that's why they would like to be tested. We're not going to confirm with laboratory, what they don't want to do. It's just better to follow the guidance. Then there is specific outreach for pregnant women. CDC said to make Zika prevention kits. We did. We have given 185 in all our WIC clinics, federally qualified health centers, other public health clinics. Essentially, that creates awareness, has some basic stuff, thermometer, condoms, insect repellents, some educational material. This all increases awareness, we hope, and we're doing it. Laboratory. So we are fortunate enough from the beginning of the very, very beginning, we were able to have a real-time PCR test, reverse transcriptase PCR, that detects RNA. In DPHL, in our public health lab, we can do that in the serum and urine. It can be done in amniotic fluid and CSF, but that has to be sent to the CDC through DPHL. There are commercial labs who are doing them. Essentially, we have, like Dr. F talked about, the times, the viremia lasts, we think, 7 days, viruria